difference for your assessment is that if it is large enough, you'll listen and you won't be able to hear anything where it is because it's all just going to be filled with air. So it's compressing on the lung. So, you know, your listener will be silent on one side, you'll hear everything fine on the other. You know, spontaneous pneumothorax can be dangerous because it can compress, you know, enough of the lung that it causes respiratory distress, possibly, you know, respiratory failure. But generally, you know, we see the more worrisome ones in traumatic pneumothorax. We'll get into that in a second.
Like
So-
gunshot or?
What's that?
Like gunshot?
Yeah. So spontaneous pneumothorax, in which air enters the pleural cavity and travels upwards, beginning to collapse the lung from the top. So, as you can see, it sort of goes up and then it pushes down on the entire lung. It sort of decreases the space that's available for them to breathe. Primary spontaneous pneumothorax occurs in patients who have no underlying lung disease. Secondary spontaneous pneumothorax in patients where there's an underlying lung disease, COPD, connective tissue disorders. Sudden onset of shortness of breath without evidence of trauma and decreased breath sounds to one side. When seated, absent lung breath sounds will be heard at the apex or top of the lung. Spontaneous pneumothorax. So this is, you don't want to introduce a whole bunch of extra pressure by bagging these patients just because, you know, you kind of already have a pressure issue and you can possibly make things worse. Okay, so it's not going to go into traumatic ones, but what happens, we'll get into, so if there's a traumatic pneumothorax, what happens is let's say you get shot. And so now all of a sudden you have, so bullet goes in here, and now all of a sudden, you know, this negative pressure system that depended on the diaphragm going down and causing negative pressure to let the lungs expand, now all of a sudden when the diaphragm goes down, it's just able to suck air in from out there. So the lungs aren't able to expand well. Now where we get into trouble is that that goes down, the air comes in, and then when you try and exhale to push it out, it gets blocked. So then air is going in, and it's not able to get out. And then you take another breath in, and more air comes in, and not able to get out. So then eventually, you know, the whole lung gets crushed, and then if it gets bad enough, then something happens we call a tension pneumothorax, where it gets pushed enough that it compresses on the heart and can kill you. But largely what actually still generally kills these patients is hypoxemia related to the pneumothorax. You know, coming all the way over and crushing the heart is generally they're already dead by that point. But you know, you'll see tracheal deviation and all sorts of stuff. And the way that we fix that is that's when we stick a needle into the chest, needle decompression.
So what are all the different kinds of occlusive dressings to fix it? I know there's one where you just put it like a piece of plastic, tape it on three sides and stuff. But what are all the other ones?
That's really it. I mean, in the end, then there's just commercial forms of it.
Mm-hmm.
You know, I've seen some that, you know,